My ID seems to say Jenny, but okay. I'll just share my slides here.
Your name is correct on the eye echo, so that's the thing that counts for
Oh,
his.
wonderful. Good. Is my screen available yet? It seems to be moving very slowly on my end. Let me turn everything else off, maybe.
Oh, you got it. Great.
We can see your slides now.
Yeah, I'm sorry. It's not expanding when I'm trying to do that. Let me just.
Oh, you're not in slideshow mode.
Geez, it's like whatever's. It's spreading across the Zoom. Everyone's computer is going to be messed up. This is.
You can send me the slides in the background if you want, Dr. Ravi, and I can share them. My
Well,
computer.
maybe I'll just go. We'll just do it old school and do it like this. Let me close this here. So, hi everyone. I'm Bheeshma Ravi. I'm an orthopedic surgeon at Sunnybrook, mainly arthroplasty, trauma as well, and I've been here I think for close to 10 years. A lot of my research has been, almost all of it has been using administrative data with ICES or ISIS, and a lot of the work I'm going to present now was done with my colleague, Dr. Daniel Pincus. In fact, much of it was the foundation for his PhD, and I was lucky enough to help him achieve those goals. So I don't have any disclosures. Everyone is doing this these days, so I just did a Google search using AI. I thought it'd be fun to look at what the mortality is for a hip fracture, and how things changed, etc. And not unexpectedly, fairly high, close to a quarter within the year. Now, this is looking at North American data as a whole, not just Ontario, but kind of makes sense. A lot of times, the hip fracture or a hip fracture is a culmination of several different factors that eventually lead to either a fall or some other type of event that precipitates a fall, resulting in a fracture. So these patients are often not long for this world because they have a lot of comorbidities and challenging living conditions that may not be addressed by the surgery. So while there are several risk factors for hip fractures, and those risk factors also predict mortality, the vast majority of them are non-modifiable. So there are things we as clinicians cannot do anything about. We can't change the person's age, can't change their sex, can't change their pre-existing conditions like congestive heart failure, diabetes, osteoporosis. We could potentially have treated these earlier, but by the time they present with a hip fracture, we can't do anything about it. What we can do something about is how quickly we operate on these patients. That's one of the few things that's in our hands as clinicians, that we can modify and potentially improve their results on. So some of the, I think it's fair to say a direct result of some of this research, Sunnybrook implemented several policies, and these are that a hip fracture becomes a B case within 24 hours of admission, or should I say presentation in the emergency room. So admission, not in some places, the patient is seen in the emergency room, but they're only admitted, say 18 hours later. But at Sunnybrook, regardless of when they're admitted, whenever that formal paperwork goes through, by the time they present, the clock starts ticking. And if they don't get surgery within those first 24 hours, they become a B case, which at Sunnybrook means that they will get done the next day. So they should be done within 8 hours. Sunnybrook is the level 1 trauma center. So The B case sometimes can stretch a little bit, but not a lot. And this means that surgeons, anesthetists, nurses, everyone understands it's a B case. It's got to get done. And if that means operating overnight, by which I mean between 12 and 6 a.m., it's going to happen. There's no delay for any additional tests. So if anesthesia, etc., would like an echo, we'll do our best to get an echo, and we'll try and get it in expeditious fashion, but it will not delay the surgery. The only exceptions to this occasionally are a patient who is, say, on dialysis, and we will coordinate the surgery around the dialysis because that'll significantly affect their mortality if we time it poorly. One other time I can think of is potentially if there's an impending hip fracture, so not a complete hip fracture, so it hasn't actually fractured, and we think it's secondary to a tumor, in which case we may organize for embolization, etc. But in that case, I hasten to add, or I should clarify, it hasn't actually fractured yet. It may fracture, or it will fracture shortly. So why do we do these things? So the studies I'm going to describe, as I mentioned, are population-based, so administrative data, propensity score, matched in some cases, admin data using validated pre-existing algorithms. I won't belabor them. Just take my word for it, or look up the original papers, which I'm happy to share offline. That all the codes have very high sensitivity, specificity, positive and negative predictive value. So when we look at this, it's mainly looking at patients over a 6-year period from 2009 to 2014, Ontarians, so adults over the age of 45 undergoing hip fracture surgery, whether that's a hemiarthroplasty, in rare cases a total hip arthroplasty, or some kind of cephalomedullary nailing for a hip fracture. Totally comprised of approximately 42,000 patients, so a fairly large cohort representing the work of over 500 surgeons and over 70 hospitals, solely in Ontario. As I mentioned earlier, it's always challenging to determine the relationship between a delay to surgical management and mortality, because the factors that predict a delay, high medical comorbidities, etc., also predict mortality. So it's hard to know which came first and how do you control for this. So we controlled using various methods to ultimately try and ascertain the relationship between surgical delay and mortality, and then compared that, and then after looking at that, also looked at issues like length of stay, costs, etc. So this work was published in JAMA a few years ago, and I think has led to a lot of the changes at a hospital and, dare I say, even a provincial level. If we look at this is where not having this is going to be particularly painful. Let me just see if I can remove that. There we go. Okay. So if we look at the probability of 30-day mortality, so that death within 30 days of the injury, and the time elapsed, from hospital arrival. So not from the time of injury, and that's a major limitation here. So someone may have presented late, but again, what we can control is the second they present in the emergency room, that's when our clock should start ticking. We find that the baseline mortality is already fairly high. So within 30 days, about 3% of these patients will die. And at about 24 to 36 hours, there's a spike, and it goes up closer to 4% after that. So suggesting that there is sort of a window here where we might be able to get to patients, and beyond that, we are consigning them to a higher rate of mortality. I apologize again for the size of the slide, but when we look at mortality within 30 days, 90 days, or 365 days, it remains the same. That threshold of about 24 hours, say 24 to 36 hours, seems to be key. That's where we need to intervene, otherwise the mortality will spike. And you can see for the 90 days and then 365 days, the differential in the mortality is significantly higher. So it goes from something like 6% at 90 days, close to 10%, and 14% at a year to, close to about 20% if you don't get to them in the worst case scenario. So it's very important that we get to these patients as quickly as possible. Obviously, there are many reasons for delay. There are issues with the patient, and that can be just a delay in the patient getting to the hospital, their medical comorbidity, other medical issues. So if they have a hip fracture, but it's actually secondary to a stroke or secondary to an active heart attack, these are complex issues that need to be managed alongside, but understandably can lead to a delay. There can also be issues from the provider factor. Maybe it's a complex fracture, so it's very challenging to fix, and the surgeon on call does not feel comfortable managing this fracture in a safe manner. That could be an issue as well. There can also be an issue with anticoagulant medication. A lot of these patients do have AFib or they have a history of stroke, so they're already on anticoagulation. And now, at some centers, the policy is to delay surgery until they wash that anticoagulant out of their system. System factors can also be there. So unfortunately, we do see not uncommonly that hospitals will transfer patients with hip fractures. So they will not manage them locally, but they will transfer them. And it is, if I can say as an aside, sometimes very frustrating for centers like Sunnybrook, et cetera, that are the high volume trauma centers to get hip fractures in as transfers, because these are ideally fractures that could be managed anywhere, regardless of the trauma volume. So when that happens, that leads to unnecessary delays that delay fracture care. Ultimately, there's also an issue potentially with OR availability. If a hospital does not have a functioning OR overnight, that's going to lead to delays. If the OR has a policy that any emergency case will cancel an elective case, surgeons are less likely to do that procedure because they do not want to cancel their elective cases because those patients have been waiting a long time. And that may lead to a delay in this patient getting surgery. Obviously, there are factors we're unable to measure using administrative data, but I think the work of the ECHO group, et cetera, is really going to drill down on these and understand them going forward. But these are issues that lead to unnecessary delays. We also performed a study then when we compared wait times for hip fracture surgery across the province, and we found significant variation. So in an ideal scenario, this would be a flat line, indicating that almost every hospital is meeting the threshold or whatever guideline it is, whether it's a wait time guideline for getting a hip replacement or a wait time guideline. In this case, getting surgery done in a timely fashion, so within 24 hours. And you can see that there's significant variation. Every hospital under this line is a variant in a good direction. So they are managing to get procedures done below the median for the province. The median in this case, by the way, is not 24 hours. It's significantly higher, but at least they're getting it done better than the median. But there are several hospitals that are negative outliers, for lack of a better term, or high outliers, I should say, that are probably could do a better job at getting patients done faster. So I'm trying to think of a nice way to say it. So that's part of the issue. Now, this is older data. I'm sure if we repeated the study now, we'd see a difference, but certainly there are better practices at some hospitals compared to others in terms of managing these patients in a timely fashion. We then looked at this from a costs perspective. So we actually just compared what are the costs? We know there's a cost in terms of mortality and patient care, but we are a single payer healthcare system. It's also useful and to get a better understanding of the costs to our system from a financial perspective of delayed hip fracture care. And it's challenging to do this because everyone starts out with a different baseline level of healthcare costs. So we use a technique called the difference in the difference. So if we were comparing the impact of intervention on myself, say versus Trish, we would look at her healthcare costs after the intervention and subtract her healthcare costs before the intervention, and that would be the first difference. We do the same thing for me. That'd be the first difference. And the second difference would be the difference in our differences in the first difference. Okay, I'm sure that's clear as mud, but it's called the difference in difference technique. And we found that if you were to operate on these patients in a timely fashion, you save the system typically 2 days length of stay and about $3,000 per patient, which translates to about $50 million a year when you look at the country as a whole. So obviously, it is beneficial primarily to the patient, and I think that's the metric we should look at. But it also doesn't escape our attention for all of us that the sooner we get to it, the better it is for our system as a whole from a financial perspective. So that's also very important. The mean wait time, I mentioned earlier that it was not, sadly, in that graph, 24 hours. The mean wait time was 38 hours. So we could be doing a lot better in terms of getting these patients to surgery a lot faster. What are factors we found, system factors I'm talking about now, or I should say factors that are potentially within our control that affect the delay? And the bigger it is, the more of a delay. So there are patient factors. If they're on a blood thinner, some hospitals take the view that we need to wash this blood thinner out. Getting an echo is a huge delay, more than 12 hours. Transferring the patient is another massive delay. So again, likely should be avoided if at all possible. Surgery at an academic hospital tends to cause a delay, but that I think is a reflection not necessarily of it being an academic hospital, but a reflection of it typically being a tertiary care center. So likely having a significant patient load and being admitted during the week because there are elective ORs running. And not every hospital has a setup with a trauma room to manage hip fracture patients so that elective care does not get delayed. So in those scenarios, the surgeon and the surgical team are more likely to manage the elective patients first and then deal with the hip fracture patients. And that's a hard thing to argue against because oftentimes the patients waiting for elective care have waited months. Unfortunately, in some cases, several months, if not maybe a year or more. And canceling those patients would obviously be a very challenging conversation. Hip fracture, typically, so hip fracture surgery, I apologize, typically does not occur overnight. This is another major barrier to timely management. If the surgical team, by which I mean surgeons, anesthetists, and nurses, and perhaps more importantly, the hospital, the system at large, does not support overnight fracture management, these patients will wait. And as I mentioned, they will not just wait for the morning. They may have to wait until the next evening, until all of the next day's elective procedures are done before the hip fracture is managed. This is adding 8 to 12 hours, perhaps more, totally unnecessarily. We looked at the outcomes of after hours hip fracture surgery. So one argument that's been made is if you operate on these patients overnight, everyone is tired, you're more likely to have complications from a surgical perspective or a medical perspective because everyone is just exhausted. And that is very legitimate. And as someone that has, performed these surgeries overnight, I would have loved if this paper showed that the complication rate was higher. Unfortunately, it did not. The complication rate is essentially the same, and there's no real difference in terms of doing the procedure overnight versus during the day for surgical complications. There's other work that I won't show here that has also shown that doing your elective cases after a night of call does not have an increased rate of complications. So that would suggest that there's a cost to the surgeon in terms of his or her sanity. I agree. But in terms of patient care, it's still quite reasonable to operate on these patients overnight. We then looked specifically at getting an echo because this is one of the most common factors that leads to delayed surgery. And we found there's huge variability. Just recall that other graph with the negative and positive outliers. There's huge variability across the province in terms of hospitals that get echoes versus those that don't. And it's a pretty significant range. Some hospitals never get echoes. Other hospitals get them on a quarter of all hip fracture patients. Whenever there's this level of variability, it would suggest that either some hospitals know something that the others don't, or the test is potentially unnecessary. The percentage of patients with coronary artery disease and congestive heart failure, although variable between the hospitals, is far less variable. So it goes from about 5 to 12% compared to 0 to 25% or 23%. So there is some variation of how heart sick some of these patients are, but that variability is nowhere close to the variability of echoes that are being ordered. Perhaps most strikingly, after the preoperative echo, none of the patients that we looked at underwent any kind of coronary intervention. So the echo perhaps offered more information, but did not actually affect care for this patient in terms of heart procedures. From an anesthesia perspective, I'm sure it did change some things, but the fact that there are hospitals that rarely get echoes and there's no real difference in mortality, etc., suggests that the echo itself, while useful, is not an imperative and is not mandatory before getting surgery for your hip fracture. And in fact, we found that there was higher mortality and length of stay with getting an echo. And you might say, and I think it'd be very reasonable to say, of course, because patients that need an echo have a higher cardiac risk, so it makes sense that those patients would be more likely to die. But what's interesting is that difference was higher at 90 days, but not at 30 days. And if the sort of a heart-related issue, you would think the mortality effect would be more pronounced earlier on as opposed to later. So that also supports the notion, in addition to the variable adjustment, that the higher mortality length of stay with an echo is likely mediated by the delay to surgery. Overall, we found that amongst 42,000 patients, increased wait time past 24, perhaps 36 hours, but 24 is what we picked, was associated with a higher rate of complications, costs, length of stay, and mortality. 24 hours seems to be a good threshold. 2/3 of patients did not receive surgery within this time frame. There were a lot of modifiable causes, transfers, potentially excess consultations, excess investigations, and overzealous concern of anticoagulants led to delays. There's obviously a significant mortality risk here, but also costs. And obviously, we have a finite amount of money in our healthcare system. And my understanding is potentially reducing imminently by a drastic amount. So we need to consider that factor as well. And while there are factors we cannot control, there are factors we can control. And some of those are at the hospital level in terms of lending supports to overnight surgery, etc., that may improve the speed at which we're able to deliver care for these patients. There's dashboards now. Trish, thank you for sending me this. So there are dashboards where you can look at, compare different hospitals in different regions and take a look at which hospitals are kind of meeting their thresholds. And this is not a name and shame exercise, because every hospital has different challenges. So for Sunnybrook, I think we do reasonably well, about 80%, but 80% is not good enough. We could obviously do better. One of the challenges we face at Sunnybrook is, as level 1 trauma center, we get a pretty significant trauma load. And anytime there's something dramatic on the highway or some other such event and people are losing limbs, etc., sometimes those cases get in as A cases, and even if the hip fracture is a B, they will get bumped by an A. And that is unfortunate, but that's probably appropriate. So these dashboards do exist and do allow for comparison. We can also look at the QBP indicator as a whole over time and see how it changes. And I think there is a seasonal variation where it tends to be, perhaps a little bit worse at fall, winter, maybe then getting a bit better. But there are variations that once we study and predict, we can then perhaps implement some of those solutions. If we can't have them year round in terms of increased OR access, we should be able to implement them seasonally, because we can predict when these fractures are going to increase. So coming back, what does Sunnybrook do? We make it a B case. We accept that there's going to be operating overnight. We don't delay these patients, typically for any reason. And the general attitude is that this is an emergency, and it's an emergency on the same level as an open fracture. It's an emergency on the same level as a foreign body in a joint. It's a B case. That's typically what a B case is. The only orthopedic emergencies that trump this are things like compartment syndrome, which is an A. So we categorize them at a fairly high level. Apologies again for the technical issues. Thank you for your time.
Thank you so much, Dr. Ravi.
I hope that was what the team wanted.
Yeah, I think it's really interesting, the study and the depth of work you guys did with all of the data is really amazing. I think that it really informs what we're doing even to today, because as you were talking, not that I was trying to be distracted, but I have the hip fracture Ontario Health e-report open in the background. And because a lot of your stuff came from 2018, they have data back to then. So I looked, and it actually, the median wait time to surgery looks fairly similar for all the regions from then. So we haven't actually made big changes across the province, is what I'm seeing. And I don't know what you think about that. Like, I know that we've made some changes at Sunnybrook, but what's your experience like? What do you think about what's happening in general in the province?
I can't, obviously, you work at one place, and the mistake is to think that that place is like every other place with the same challenges and same priorities. But my own experience when I was a resident is that there was significant variation across at least hospitals in the city in terms of how they prioritized hip fractures. Sunnybrook, even as a resident, tended to sort of have that saying, you don't let the sun set twice on a hip fracture. That was the attitude. But I think it really became militant after Daniel published these articles. I think that when Sunnybrook started taking it very seriously. I don't think every other hospital has, and they all have their own challenges, as I say, because as a trauma center, we're limited sometimes because we have such a high volume, but I think the hospital also has a commitment to performing these surgeries in a timely fashion and maintaining a quality. So I know Hans is going to talk later about making sure every patient is weight bearing is tolerated immediately after, so it doesn't delay their movement. So uh, I can't speak to other hospitals' priorities, but Sunnybrook takes that very seriously. So they want every patient managed well and managed fast. And I think it's great that they extend that attitude to patients with hip fractures as well.
Yeah.
One thing that I feel, and this is not a comment at any particular hospital, but just a general thought, I think, is that sometimes people, surgeons or whoever, take the attitude that, this patient is young, we have to get it perfect because they're young and they're going to live with it for the rest of their life. And that's 100% true. But I think an equally important argument is that this person is old. They have very little physiologic reserve. If we don't do this quickly and do it well, they may not survive it. Whereas a younger person might be able to survive something because they're just generally stronger. So I think the Sunnybrook takes that attitude, and it's reflected in how much they push it.
Yeah. If you could, I don't know if there are other questions, but I'm so curious about this. Like if you could have a big key resource across the province, like what would you say is a resource that seems to would help all of this, would help other
More OR access.
more.
No, because that is the limiting factor, right?
Yeah.
Because we've shown there's so much we can't modify.
Right.
Optimizing these patients before surgery, potentially impossible. You'll never get them fully optimized. They have a lot of issues. It's timing to the OR. Get them to the operating room. And I also think it's not fair to ask patients who have been waiting months for an elective surgery to then be say you're canceled because we had 3 hip fractures come in last night. That's not fair to them. They waited a long time. So you need to increase OR access so that those cases get done and these cases get done. And I think that is the only way that um, we can address the issue in a major way.
Mm-hmm. Jenny, is that you with your hand up?
Yeah, it is. I was hoping to ask a question because I've realized that this is a problem in my center. You talked about DOACs and anticoagulants delaying time to surgery. Can you comment a bit more about that? And who's concerned about it? Is it the surgeons, the anesthetists, or the internists?
In my experience, it depends. It's typically anesthetists because these surgeries, if it's a more invasive surgery, so some kind of a hemiarthroplasty where you're making, a reasonable incision, then you can identify and ligate the bleeders, and it's just going to be a bit bloody. If it's a nail, then the incisions are a lot smaller, and potentially you're dealing with it. From an anesthesia perspective, they can't do a spinal if the INR is too high or the patient, because that would be catastrophic if there was a bleed. So they would have to do a GA, and in some cases, maybe you can't do a GA for whatever reason, and then that's a factor. But typically, in my experience, it's been anesthesia. Medicine, I mean, they may be concerned that, but it's not something that is going to be made better by delaying surgery and then having the patient die for that. So I think if everyone took the attitude of these, this is an emergency, they would potentially document their notes to reflect that. So I think one of the internists at Sunnybrook, hope you won't mind me quoting, but Don Redelmeyer will write, ideally could optimize, but surgery must happen ASAP. So these are my recommendations, and I think that's it. So anesthesia, to answer the question, Jenny, in my experience. So I can't comment on everybody, but in my experience.
Yeah.
Thank you.
Frank, do you have?
Yeah, I was going to say great talk. I have so many questions, but actually my main one was, we're in an academic tertiary level trauma center here at LHSC too. One of the frequent things I get is the surgeons are on board. Everybody is militant's a great word. I interact with residents all the time, and the same priority doesn't always translate to them. And I was wondering, jurisdictionally where you are, do you have like a something where the emerge docs admit, or is there kind of a mandate that they come admit them and see them first, or what's your dynamic to kind of expedite, I think, the admission process, not so much the OR, but the first part, because it is a low priority when the residents are super busy and doing other things. It just, I find that delay can actually range anywhere from like 40 minutes to 8 hours at times. And so I just wondered your kind of experience locally.
Jeez. Um, Residency wasn't that long ago, but if I took more than a couple hours to see someone, I can only imagine what Dave Stephen would say. Hey, Trish.
Mind.
Yeah, yeah, I don't think I'd be here right now. But anyway, so I think that some of the things that the residents do at Sunnybrook that we did, and they do even better now, is um, a daily handover email. So there's a handover email that goes to all the residents, all the staff, and relevant allied health professionals that they can look at. And so it's documented. These are all the traumas that came in. These are all the consults that came in. And right at the top is these are the surgeries that are booked or about to be booked and what priority they're going to be. So that is a daily reminder. And I feel that that has helped the residents. It helped me, and it certainly seems to be helping them internalize that this is an emergency. So sometimes they will write down in the handover, they will say, patient presented at this time to be booked as a B or to be upgraded to a B at this time. And so they take it seriously for that reason. And I would argue that if residency is anything like it was when I was a resident, which again, I swear is not that long ago, then a staff person telling the residents to ensure that these patients are prioritized is the difference between them being prioritized and not being prioritized at the end of the day. So if the surgical team reinforces that message, I can't believe that the residents wouldn't follow.
Nope,
Well,
that's helpful.
I think the one thing too, I like what you said about that, that I really see a big difference since we implemented the handover list. That's made a big difference. And I've also seen occasionally, like when the ortho resident on call is busy, they're still in the handover list. It'll get noted that, this emergency was noted and this happened by the trauma team leader and ortho is coming, but we know it's on the list. Like the trauma team leaders seem to have the ability to report in, which is great. Sort of gives that better dynamic, I think, between the ortho residents and the emerge residents. Is that accurate, Dr. Ravi? Or
100%. No, and again, they're relevant to seeing the handover email is the TTL or someone else. So if they're seeing it too, it gives them another touch point. They're not wondering who to reach out to, or I got to send like the residents missed this patient for whatever reason. They really got swamped last night. I just want to make sure. So they get it. They can let the person know. So I think that facilitates things a great deal. So the handover email for us has been very significant.
yeah, for sure. Anna, I see a question from you. Or see your hand up.
Yeah, sorry. I was just going to add, so I'm the nurse practitioner on the ortho trauma unit at Vic, and we do the handover email as well. And I do find it helpful, even from my point of view, being the nurse practitioner on the floor, is sometimes it'll be like, oh, medicine consult pending prior to OR, and we can help facilitate some of those barriers to be mitigated to facilitate the OR times as too.
Yeah, that's a good point. I see in the chat, Rayanne asked, how do we access the e-report, the report that shows various hospitals and their performance? So we had an echo presentation from the Ontario Health folks last time. Was it that soon? Anyway, we can send instructions on how to access that report, and that will be that presentation is actually on the iEcho if you go back on the Echo website, and Sylvia, wonderful, thank you, is sharing some steps so that people can access the e-report. And if you want, if you want to see live, um, what that looks like I just had this open in the background because I was like, oh, I wonder what this looks like now. And this is what it looks like right now. So if you're looking, that's what I was talking about. There's our data for 2018 from all the regions, this is aggregate data. And here we are now. And it kind of looks the same. If you look at 24 hours, it looks different. There's a little more variability between the regions, but you can actually do really neat things with this report. Depending on, do you want to look at your own hospital compared to similar other hospitals? You can drill it all down like that, or you can just look at regions. There was a little more aggregate regional data that I'd love to have, but the OH folks and I will talk about. Hopefully that's.
Thanks so much for all the information. Super helpful. Thanks.
Yeah, no problem. Any other questions for Dr. Ravi? I actually have a question. This is something I don't know. Like when was the sort of, I know we used to make them, we have made them C's and then B's. But when we made that shift in the OR to sort of put them as B's, make them top priority, did we actually write new policies around that? Was that important to do?
That I don't know.
Yeah, I feel like Dr. Yi made I think that's sort of leadership, probably that needs to happen. One of the things I think that Jenny and I and the team have seen is, regional champions like Dr. Ravi, Dr. Crater, are really, really important in terms of making change happen. And, having someone around like Dr. Ravi and Dr. Pincus who are doing all this big data research, it really does show how important these things are, right, to the whole system. So thank you, Dr. Ravi, for being on my team.
Oh, yeah, my pleasure.
Sorry, I'm not sharing you guys.
Thanks so much, Dr. Ravi, for presenting today. Can I ask as well, could we get a copy of some of these papers that you were referencing, and maybe we can upload them onto the website for resources, particularly for our members who want to take them forward to their divisions, to show some of this data too?
I'll send it to you by end of business today.
Thank you so much.
Great.
I think that's actually quite a nice segue to Dr. Nabil Kamasudin and his team from Carleton Queensway. So today we're not going to be doing clinical cases. We're going to be talking about a QI project that Queensway Carleton has been undertaking to try and get their patients to the OR within 24 hours. So this is really another center implementing some of the factors that Dr. Ravi was talking about. So I'm going to hand it over to Nabil and the team.
Thanks, Jenny. Everybody can hear me, hopefully. Yep, awesome. Thank you. So thank you for that introduction. My name is Nabil. I'm one of the physicians at Queensway Carleton Hospital. We have a similar initiative to Sunnybrook with some modifications, and I know we were asked to talk about that a little bit. A little bit about me, and it's something that I will reference back to. I'm a family medicine doctor. I graduated from residency in 2020, and then I joined Queensway Carleton Hospital about just half a year later and found myself somehow into the chief of geriatrics role about a year and a half later. I have a bit of a wider scope. I do orthogeriatrics, TCU, ALC, rehab. We have a subsection of our rehab that focuses on cognitive assessments too. So we call that the care unit. I do a little bit of acute care, and I also do a little on the side, street health. Why is that all important? In terms of background, I have no geriatrics background. I have no orthopedics background. I have no leadership background. I have no quality improvement background. These were all things that I was thrown into and had an immense amount of support from the hospital, which we'll talk a little bit more about when we talk about initiatives in themselves. In terms of background, for Queensway Carleton Hospital, we are designated a large community hospital. We have about 350 beds. We don't have a robust program around residents and fellows. Most, if not all, is governed by staff physicians with respect to clinical care. And every so often, we will see residents and fellows in acute care medicine or ICU. But for by and large, particularly in orthopedics, we don't see residents and fellows. We share orthopedic care across most of Eastern Ontario. Kingston and Pembroke help us out quite a bit too. And a lot of that is actually centralized by something we call the command center, and that's governed by the Ottawa Hospital. So that's our level 1 trauma center with being the academic tertiary care. We do have specialized geriatric services. We have a geriatrics medicine team. We have an outpatient geriatric day hospital. We have geriatric psychiatry, but often these resources are fairly limited, and we call them more or less traveling services. So they come in a couple days of the week, they provide services, and then they are essentially given recommendations that the inpatient teams will follow through. We do average about hip fracture cases, 300 in itself over a fiscal year, and we are a NISQIP institution. I forget if we have talked a little bit about NISQIP in the ECHO, but it's essentially a national surgical quality improvement project and program where a number of institutions across North America and internationally are actively involved in collecting data and presenting it forward. So a little bit about us too. We have the same issues as many other hospitals, if not all. We do get extremely busy. This is one of our sort of escalation levels, talking about handover. We get daily reports as to how we're doing in capacity. And this is a good example of a really, really bad day that we had where we almost hit 120% capacity. Our surgical capacity was out of control, and our emergency had 44 patients waiting just to get a bed in the hospital. There are instances and patterns, particularly winter. I also like Google AI, so it actually does know a pattern that we see frequently, and it's called fracture load, where once the Rideau Canal opens, we do start seeing, unfortunately, a larger number of fractures that hit our doors, and something that does affect our capacity in unfortunate ways. Now, one of the quality improvement projects, so we have a background, we do know hip fractures are very concerning. It is something that is highly recognized at our institution over particularly the last few years. And where that comes from is multiple domains. Our NISQIP group wise, year to year, we have been identified as needs improvement. We have been identified as a high outlier when it comes to hip fracture mortality, geriatrics, orthopedics, amongst other surgical parameters too. It is important to recognize Ontario Health, who also has their surgical quality improvement program, and then the hip fracture toolkit itself too, where quality statement number 2 identifies that surgeries, particularly for hip fractures happening earlier, do demonstrate better mortality rates and safety data, as we've already heard today. Then we have our own institutional. We do talk about hip fractures quite a bit. We have multiple committees that this has come up at. That it is actually essentially our agenda on a monthly basis, where we have our quality care committee, we have our morbidity and mortality committee, we have our hip fracture working group, we have our medical advisory committee, and our peri-ops committee. There are actually a number of other groups that I didn't identify, but these are sort of our main domains that we often talk about hip fractures. And it's in these multiple areas of institutional care that we have actually identified where C24 might be able to actually help us out. So what is it exactly? C24 is a proposal that if we assign a subsection of our C cases where hip fractures are designated as a higher priority, we can see those patients actually happening or having their surgery within 24 hours. So it's a busy slide, but you'll see that essentially amongst our C cases, hip fractures will have the highest priority. The goal is still to try and get them under 48 hours. Right now, at baseline, we see about 88%, but we're hoping to get that up to 95%. And we're hoping to identify to all these cases as C24. So that's a troubleshooting in ourselves too, that at least when we see these cases, we do actually need to identify them as soon as possible too. In turn, we're hoping that will demonstrate something from a mortality perspective. So for what it is worth right now, this is still the same fiscal year. So we are still looking at how this data is going to develop. So I don't have complete data as to how it's going, but I can describe a little bit from what we thus far have. And we are submitting this to the SQUIP group where they are looking at this actively and looking at us as to how we're functioning at this current time. So a little bit more detailed too as to what is it exactly. So background, as we've already heard, these patients do benefit from having the surgical repair sooner than later. We do a slightly different, so we won't identify them as priority B. I forget, again, I'm not a surgeon, so case Bs, I believe ours are between 8 to 12 hours and A's are as soon as possible. And our C's are then essentially within 48 to 72, I believe. In that C cases, we are essentially saying that hip fractures will be reserved for as soon as possible once a C capacity opens up. We may change that to a B if there is some sort of clinical condition that has changed. And so this, in terms of talking about policy and how we had essentially codified it, the revised process essentially demonstrates how we're actually doing this. We do help Ottawa Civic Hospital with trauma cases every so often, and so we do actually have designated space. And in this sort of scenario, we looked at where do we have space? How do we actually get these cases? It's one thing saying that, hey, listen, these cases need to go as soon as possible. It's a whole other problem when you talk about OR access. How do you actually get these patients into them, even if you designate them something higher priority? So we looked at where we have designated spaces, and we have one specific area where the ortho trauma room is reserved for those more urgent cases. But if it's not being utilized, then we just switch it and we use a C24 protocol in those cases. So the biggest question is, well, how do you do something like that? And I actually referenced to something that I remember more as my university undergrad and first year calculus, where they started talking about a square root of -1. And that blew my mind because that's something that you were always told is not actually possible. And then somebody said, and I know I'm trying to recount here people's knowledge about calculus, but they essentially said you can call that an imaginary number. And therefore you have square root of -1 now. And this is to me pretty resounding when I think about it, is that for the longest time, and I know at least when I joined Queensway Carleton Hospital, there was a huge focus of orthopedics being an orthopedics problem. Orthopedics equals orthopedics. Orthopedics cannot equal anything else. It's not geriatrics, it's not internal medicine, it's not administrative. Orthopedics is orthopedics problem, therefore orthopedics must fix it. And I think over the last few years, particularly with NISQUIP and the data that we have and what we have internally when we look at the number of committees that we have started looking at hip fractures, it turns out orthopedics is actually a multitude of problems. It requires multiple domains to be affected and involved to be able to help. Therefore, it takes a village to fix these issues. It requires teamwork to fix these issues. With C24, we didn't have to invest more money. We didn't have to invest more resources. We didn't have to do a literature review. We didn't say that we have to shift the balance of scales to say that one quality improvement project is more important than the other quality improvement project. We looked at the past data. We looked at what we have already. We looked at what Ontario Health has already demonstrated. And we said, this is something we could consider doing, and we can do it as a trial. And so that brings up, well, How can you just implement a project like that? What are the challenges? What are the problems? How do you actually look into those things? And we said, well, we know what the variables are, particularly OR access, but we're going to do it as a trial. We're going to try it out. We'll see what data we collect. We'll see what issues come up, and we reconfigure. And turns out, so I chatted with some of the surgical leads, surgeons are still in the OR. The OR is still being used appropriately. The surgeons who initially had brought up concerns, particularly in the perioperative committee about, well, why does a gallbladder surgery not take trump over a hip fracture? Why does my nephrectomy not take trump over your hip fracture? Well, it turns out it's not actually affecting it. And the surgeons are still pretty happy, and the surgeons do not feel that their time has been devalued. And that's a good sign. That's demonstrating right now that this priority, this reconfiguration of how we code our hip fractures without extra money, without extra resources, without needing to invest a great deal of time in our literature reviews, has not actually affected the quality of care from a negative perspective. So this is a little bit of the data that has come out. This is 2025 right now. As you can see, most, if not all, cases now are actually happening under 48 hours. And interestingly, they're almost hitting the 24-hour mark now. And most, if not all, cases are hitting the C24 label and designation. Where we struggle with right now, that is an ongoing review, is that we're not in theory a 24/7 hospital. And so those problems of overnight, weekends, are still cases where we're not able to designate those patients C24 and often becomes essentially an expired code. So those are things that we're still looking at, and we're still in the 1 year mark right now. This is the qualitative piece right now with the amount of information that we have to give the surgical quality improvement project. We're not specifically measuring the qualitative piece yet, but this is where, as somebody who is working in the rehab floor, somebody who's doing orthogeriatrics and working on the ALC floor, I am noticing it. Our patients are going into surgery faster. They are actually eating faster. There is an unusual pattern that I often notice with these hip fracture cases where the first 24 hours they have a very difficult time just eating, just getting something in. And these things are improving. Patients are being nourished faster. Their pain control is improving faster. We are mobilizing them faster because a culture is being promoted where doing these things earlier and faster and efficient is actually changing how we affect these patients. Delirium rates are going down. Our medical errors where medications like home medications not being ordered, heart failure not being optimized, pain management not being appropriately reviewed, those medical errors are also improving because these patients are being seen faster. And I know this is everybody's favorite parameter because it matters. Bed flow is improving. Our patients are actually getting out of that emergency department. Our patients are actually hitting the rehab floor faster. Our patients are not being bogged onto these surgical floors and inevitably waiting long times just to get to that OR. So that comes down to really next steps. We don't have a robust research network in our hospital. We don't have robust, high-level expertise in our hospital. And that looks towards us trying to present our data, but also looking at, well, how do we use all this information? How do we use these innovative projects to start being better? And what we're learning in a lot of this is that teamwork works. Our hip fracture working group, which was just a sole group, has now been divided into pre and peri-op, into a pain group, a post-op group. Our orthogeri model, which was isolated to just physicians, is now looking at how to expanding and creating dedicated teams. Our rehab group, which initially was fairly black and white, if you met a certain criteria, you ended up on the rehab floor. Turns out these patients are complicated and black and white does not work. And so suddenly, these patients who seem appropriate for rehab, well, we're going to find a way to just streamline them, bring them, and then deal with the problems as we see them. We have a delirium steering committee that is actively looking at hip fractures and delirium incidents, optimization, and really weaning out those parameters that are affecting our hip fracture patients. Where our frontline staff is something that we have heavily now focused more and more on. is that, again, we don't have those high level expertise who are able to come to our institution or work in our institution. And so it's really important that we promote our frontline staff who see this day in, day out, who establish patterns. And, for C24, a very good example is that I wasn't part of it at all. I was never even close to C24. Where it came upon was frontline staff who brought up an innovative idea, who suggested that this is something that maybe could work and has low risk and a very high reward. That's important. And that comes to the second part, is really promoting those champions. And, I may not have a high level geriatrician, but I do have that nursing champion who has noted and understood and feels that it is important that we start addressing the issues that they are experiencing day in, day out. I think it's important for education to be really emphasized. We don't unfortunately have, or we didn't have as much of a focus on things like journal clubs and mortality rounds. But over the last few years, we have already started looking at how do we sort of create departmental mortality morbidity rounds, but also start bringing over new research and new evidence. But that also is contingent on having a regional network like the Project Echo. We have provincial guidelines like Ontario Health and the hip fracture toolkit, and looking at optimizing those parameters. Those information spread amongst our institution, and then that information starts spreading to other institutions. And that's promotion of education, I can tell you, has made a marked difference for us, at least over the last few years. And that comes to the last part that I think is probably one of the most hardest parameters that we are still looking at, and something that where I focus a lot of and I'm trying to promote, is oversight and contingency. As an institution alone, we felt alone and we didn't know how to actually proceed. I think having the quality improvement project teams, having Ontario Health, having regional experts like Sunnybrook Hospital, being able to present data and actually coming to us and demonstrating knowledge to us, having that oversight as opposed to leaving each institution to fend for themselves, has created a very positive culture. It helps us when we start thinking about, hey, listen, when we are in that high level escalation, there's 44 patients waiting in emergency and our surgical capacity is getting out of control. What is our contingency? What, as a regional and a provincial system, is in place for us to protect us from, unfortunately, being part of a plan where patients get harmed? And I think C24 is a good example of how, from a regional, provincial perspective, from an institutional perspective, from a frontline and champions perspective, has resulted in good patient care and is already proving to be successful. So thank you for that. I hope some of that made sense in terms of what C24 is and how we came upon it and what our challenges and what we're looking for in the near future. I do want to really give out our contributions to Dr. Joel Weaver, who wasn't able to make it out here, and Amanda Saunders, both high-level surgical champions, quality reviewers who are actively in efforts looking at continuing to help us optimize hip fracture care in our institution. Don't know how to stop share here. There you go.
Thank you, Nabil. Wow, great project. And I love how it shows what a big difference the frontline team can do when they're passionate about something. That's really great. Really, really great. I don't know if Jenny's still, I think she's still online.
I am like Nabil, I have just got to congratulate you guys on the work that you've done. I mean, like from the initial conversations that we had, right? The other day I just had to go through the e-report to prepare for our hip fracture meeting. I was looking at these data and I was like, Queensway Carleton are incredible. And I think I'm actually going to have to use your data as benchmarking for my hospital and let them say, hey, look at what they are able to achieve. And to be able to hear your story and how you do that, was particularly when there are so many variables, is just really inspiring. And I just want to say as well, you don't need to have a geriatrician on your team to do this. You just need somebody who is passionate about this work. And it could be anybody from the interdisciplinary team to take it forward and to run with it. And I think you guys have really demonstrated that so well.
Thank you. And I do want to give you kudos too, Jenny, and a lot of folks up here who have been very receptive to me simply asking simple questions. Well, difficult for me and hopefully simple for a lot of folks here, where I think having that access makes a huge difference. Where, yes, there are a couple of weeks where I may not have a geriatrician, I may not have a senior physiotherapist. And I think having these networks and access to resources does make a marked difference.
Yeah, when we share and talk to each other, it's so helpful, right? So good.
I know Jamie has her question up, but I'm just going to put a quick plug. Um, Ellen has put the evaluation in the chat. And I know I say every week if you wouldn't mind filling it in, but specifically, we are looking to do more of these quality improvement talks, like what Nabil has done today, to kind of go through things that hospitals within Ontario have done and achieved. If this is something that you want to see more of or you find it helpful, please give us that feedback and let us know. If you think this is helpful, we will continue to do that. And I'll leave it with Jamie then.
Thanks, and thanks, Nabil. I thought that was a really interesting talk, and you guys have obviously done some really great work. I have two questions. One of them I may have just missed because my internet was kind of going in and out and I was frozen at the beginning. But so what is the difference between coding them as a B versus coding them as a C versus coding them as a C24? B, I think you said it has to be within 8 to 12 hours or 8 to 24 hours. And so why do you think that the C24 is different than that? And then my other question is, why do you think medication errors are improving? Is it just because people are getting seen by somebody that they're going to be admitted to and they're not in a back hallway ER somewhere where maybe they're not getting as much attention, or?
Yeah, so I did ask Joel about the B and the C24 because I was intrigued by itself too. And it's purely a simple way to demonstrate what will trump over another. And in this case, yeah, I believe it was 8 hours. It might be a little longer than that. I know I see some of the surgical guys on this from Queensway here. But essentially it was that. So within the C group, hip fractures will trump everything else. Amongst the B group, though, which we have certain coding and certain cases that we'll go through, that will always trump over all C cases unless we change the C into a B itself. And a lot of that, I imagine, and this is me extrapolating, is to be able to at least help the surgeons understand where we're coming from a hip fracture perspective. And it is probably a parameter that will be revisited. And I wouldn't be surprised if we said, hey, listen, we're already actually doing them within 24 hours, so might as well just make them a B. And so it might be just a step up. And I speak that as somebody who, unfortunately, has no desire to be in the OR. And these are codings and things that have been developed in a certain way to probably help the surgeons out from a global perspective, but also trying to make sure that we don't inadvertently change those higher level B cases that do need to go at a time that is necessary. Sorry, Jamie, what was the second part of that question?
Of why, but no, I think that makes sense. And I'm not a surgeon and no desire to be a surgeon either. So I don't understand all the nuances around that. But I just was wondering if there was, why not just make them a B but that makes sense. Oh, and my second question was, why do you think that the medication errors are going down with this? Is it just because you're not in a back hallway somewhere potentially, or is there something
Yeah,
else?
yeah, and so that's a very big topic that I am actually quite passionate about and something that I'm looking at very closely. The longer the patients are waiting for surgery, then there's an exponential increase in variables that affect the patient's care. So medication transfers. I don't know what EMR everybody else here has. Right now, we're in Meditech Expanse. We are eventually going to move into Epic, but they have similar modules. So you have transfer of care from ED to orthopedics to surgery to the ward. So there's four levels of transfers that occur just to get into the OR. As patients wait longer, there's that inevitable cycle of, well, you're going to eat. Actually, you're not going to eat. Actually, you are going to eat. Actually, you're not going to eat. And then there's the medications. And I think this is the harder part where we don't have residents and fellows. Most of, if not all, the physicians, except for maybe acute care and ICU, are in-house. And so when medications are not actually started, if you're waiting for 48 hours, that heart failure is not being optimized, it's actually being missed. And our patients are getting more and more complicated where if I do get consulted as ortho Jerry, I come in and say, hey, listen, actually, you may want to hold off on those IV fluids. This guy's ejection fraction is 15%. Actually, you may want to actually ignore the fact that they're on a DOAC because they're likely going to die from this hip fracture. So we may need to go sooner than later. And those conversations are essentially being removed now because when I am actually on service, patients are going within hours. We had one ALC case where a patient, we have an offsite ALC unit where a hip fracture was done. It was diagnosed at 1 p.m. by myself. I brought them through emergency, and by 4 p.m., they were in the OR. By 6 p.m., they're actually returning to the ALC unit. Why? Because it was just one of those things that we could do quickly and we had a good capacity. And in that 5 hours, it's really hard to make a medical error. It was just go, go, go. And by the time they came back to me, I said, I know what exactly they need to be back on. I know what medications. I still remained MRP that whole day. So that's what I'm noticing. Certainly a point of contention in that, unfortunately, we're probably not collecting it yet, but it'll be something of interest to look at in the near future for us.
For sure, that's a good point that there's just not enough time to make errors yet, and there's less turnover with nursing and physicians and everybody else. And so over 5 hours, that's still one shift versus if they're sitting in emerge for 48 hours, then that is several shifts of nurses and physicians. And so that's a good
Easily.
point.
Something
Thank you.
we're very much noticing.
Jenny, I see you have a question.
Yeah, I think that's incredible that you're doing that. Like I was just on service a couple of weeks ago, and the bane of my life right now is
See one hand up
SGLT2.
here. I'm not sure if I'm going to chair that one
Oh,
hand.
the bane of my life right now is SGLT2 inhibitors and euglycemic DKA because patients are inappropriately getting those medications. I don't know if you can speak to this, but in one of the slides you mentioned that this was a SQUIP project. Are you able to speak to what that is?
Yeah, so I did actually ask into it, and this is where again contingency and oversight becomes really important. So what I'm understanding is that we were initially with NISQUIP meant to share our data, and over the last couple of years now, they're asking that we actually be part of a quality improvement project. And a lot of that is actually apparently associated with our funding. And so we were more or less told to do something. It wasn't apparently something very specific, but we were just told to do something. And in this case, the Peri-Ops committee reviewed all of it, and C24 seemed to be felt to be something that could be easily achieved, and that's where we submitted the data. And I think that's the data that is still being submitted monthly to the quality improvement project. And I think by the end of mid 2026, it will be reviewed again.
Perfect. Thanks for clarifying that. And I don't know if we've mentioned it before, but physicians have a CPSO requirement to do quality improvement. So if you register this as a CPSO quality improvement, you will also, all of you will fulfill your QI requirements.
I got my 2026 reminder, so.
Great. Are there any other questions or comments? I'll hand it back to Trish because I think I do have a bit of feedback on my end.
I think you were sounding pretty good, Jenny. It's good. The the I really think this quality improvement project, like on top of the research presentation, sort of looking at big data and then sort of drilling down to a really beautiful example of a team making great improvements in a small case, which could be scaled, right? It's really so inspiring to see the whole spectrum today. So I don't know. I think we've got about 8 minutes left. If anyone has any other questions, I think Dr. Ravi has quietly slipped off to his clinic, but If you have any questions for Nabil, that'd be good. I think the one thing I would say that probably everyone online who's sort of near surgeons would appreciate is every hospital, as you might have guessed from what Nabil is saying and from what Dr. Ravi is saying, every hospital in every community is going to have a little bit of a different mix, right? So Nabil sees all the, what did you call them, Nabil? I thought that the fracture lude,
Yeah, it's a period in our
like
phase that in
different
our area.
interlude, but
Yeah.
it's we don't have the canal here, so we don't necessarily see the same thing. Like it's really that'll be really regional, and I think in terms of approach, anyone else can jump in here. Understanding both the big data in the province and also the regional data for each region and each hospital is going to be different. So the way we allocate our OR resources, it'll be a little bit different depending on your mix. The Nabil saying the canal's quite safe. Everyone can go skating, don't worry. I'm not because I don't want to be on your fracture list, Nabil. I'm sorry, you're doing a good job, but I don't want to experience it. I think up north they'll have different issues than in Toronto, for instance, right? So I think it's really important that we have an understanding of both the big data and the local data and everything in between, because that sort of helps us manage our resources the best. Any other burning questions or comments from the group? Please
I'm just going to say a quick comment and a plug. One of my colleagues, Dr. Kristen Clemens, actually looked at ICS data a couple of years ago to map hip fracture incidents across Ontario by month. So I can post that as well because that, like understanding, like you said, what your data looks like may help with some of this resource allocation.
Right, exactly. Last plug for clicking that link that's in the chat and giving us some feedback about today's session would be great. That helps us plan for future sessions. We have some great stuff in the IACO coming up, so we'll be very happy to have everyone join us again in 2 weeks. Did I catch everything, Jenny?
I think so. Thank you so much. And hopefully I'll be able to fix my camera by next week. Although I think maybe you should do this more often, Trish.
You're good. You're good. We're a team. This is what we learned from Nabil. The team is important.
Absolutely.
Okay.
All right. Thanks, everybody.
Enjoy your 5 minutes extra back, everyone, and see you in 2 weeks.
Bye.